Yeah, so as they alluded to, I am a native New Yorker. So Dr. Rosenblum did sort of volunteer me for this. And being a native New Yorker, I know when the Godfather is making you an offer, you can't refuse. So here I am. And so without further ado, I'm going to present this case. I am a fledgling attending in every sense of the word. So the case I'm presenting is actually one that I had as a neuropath fellow, and we rotate at Boston Children's Hospital. So this is a pediatric case. This is a 12-year-old boy who had a past medical history of adrenal neuroblastoma, very classic. He was diagnosed at age 7. He was treated with chemotherapy, surgical resection, a stem cell transplant, and radiation. And he did really well. From that time forward, he had, responded well to therapy, no evidence of recurrence, and then on a follow-up, sort of his routine screening follow-up scans, they noticed this dural, certainly a large 2.5 centimeter, if not dural base, certainly abutting the dural enhancing lesion in the posterior fossa. And then retrospectively, when he was questioned, said he had a history of headaches for about a month. So of course they wanted this out post-haste. Oops, back up a bit. Sorry, going in the wrong direction. Pretend you didn't see that. So this is what we saw on histology. And this is a really unusual, presentation for what we saw. You see these nests and cords of fairly bland-looking cells in a very prominent myxoid, somewhat bubbly but not quite physilarifus background, certainly very myxoid. The cells themselves are bland, ovoid to spindled histology, very delicate, possibly imperceptible nucleoli. There are these strands, at best maybe ropey collagen present in between. And in some areas, this myxoid area has become quite prominent, where you have these kind of lakes of myxoid material. So we were almost quite baffled. So you can imagine in a patient with this history in this location, the differential diagnosis was broad, to say the least. Being a neuropathologist, you try to square peg round hole things into the stuff that you feel most comfortable with. So wondered if it was possibly, a meningioma with very prominent myxoid changes. Because of that bubbly myxoid background, could it be a weird chordoma? Because of the location, is it some odd presentation of a pilocytic astrocytoma? And then we start to sweat a little bit, because now we're getting out of our wheelhouse and we're into things that really probably belong a little bit more to the bone and soft tissue pathologists, but they certainly have been well described in and around the brain, so we have no right to not consider these. And there's a wide list of possibilities in that realm as well. So we went to the immunohistochemistry lab and availed ourselves of every possible service. And I think what's really interesting and telling here is I'll show just a few key stains, is that if you really tried very hard to believe that this was a meningioma and you went to your typical EMA staining, there is EMA positivity. And you might think, okay, one and done, and try to sign out the case that way. GLUT1 has been described in a variety of entities, including carcinomas, but has been described to have strong positivity in certainly the higher grade and more atypical meningiomas. So even if you went that far, you probably wouldn't get disturbed. But if you did, consider things outside of the neuropathology wheelhouse and went to do a CD99 and a Desmond, you'd realize that this is definitely not one of the top 3 sort of diagnoses for that area. So I guess you could call it kind of local factors, maybe the Fletcher effect, about thinking of what we thought this was. So just for sake of completeness, all of the other immunohistochemical stains are pretty much negative. There was some focal CD68 in some areas of it, but for predominantly negative. So we went to FISH, and this is a commercial Visis break-apart probe for EWSR1. And you see here separation of red and green signals consistent with a rearrangement of EWSR1 in 88% of the nuclei. So now we are pretty sure we knew what this was, but we knew what we might want to call this. We went to our targeted exome sequencing panel, which is fairly analogous to the MSK impact. I think at the iteration that this version was, it was about 300 genes, cancer genes, and some 35 introns covered for the purpose of trying to identify, in addition to single nucleotide variants, to also try to comment on possible structural variants based on the targeted exome sequencing data. So it basically takes all of the broken reads everywhere where the fidelity falls off from the reference sequence and tries to map a variant contig to try to comment on the possibility and the amount of, I guess, confidence you would have in a structural rearrangement. And the partner that was identified here was CREB1. Oh, and I have an extra B in that, so it's CREB1 in intron 7 with intron 8 of EWSR1. So we thought that this might be a MixWeb variant of so-called angiomatoid malignant fibrous histiocytoma. These were recently described by Fletcher et al. They have the characteristic morphological features of classic angiomatoid fibrous histiocytoma, at least focally, within a very prominent myxoid stroma. They've been described to be positive for EMA, Desmond, and CD99, somewhat patchy, and CD68 can be occasionally positive. And they have identical chromosomal alterations as the classical AFH, so we'll just talk about that for a minute. So AFH, as you all well know, is an entity with intermediate malignant potential. It's most commonly found in soft tissue extremities, typically younger individuals. In rare instances, it is identified as a primary intracranial lesion. This is the classic AFH. And they have these characteristic chromosomal rearrangements involving EWSR1, most commonly with CREB1, but also with ATF1, and a FUS ATF1 rearrangements have been described. And the classic features include a fibrous pseudocapsule, peritumoral lymphoplasmacytic infiltrate, can even be seen as like a very strong cuffing, with blood-filled cystic spaces. And the cytology is described as histiocytoid to spindle tumor cells, and they can have a very multinodular whorled sheet-like or fascicular growth pattern, which we did see in our case. So I was thinking it was really cool, and here I was trucking along with my little project, and then, Christina Antonescu and Mark came and shut me down by publishing their own series, which was actually really kind of interesting because they found these EWSR1 fusions with the whole CREB family transcription factors in myxoid mesenchymal tumors in the intracranial location in most of their cases. So this was a series of 5 cases, and I'm just showing some figures from their paper here, where you can see that these tumors certainly look very similar to the ones that we'd seen in ours, although there is a range of histological features amongst the tumors. One thing that they saw that we didn't see in our series are these sunburst, very distinctive amyothoid collagen fibers. There was collagen in some of our lesions, but that you saw was just typical strand type stuff, maybe at best row B, not anything like this. And when you look at the actual cases that they included in their series, there's some interesting things emerge, in that all of the patients in their series are fairly young. Obviously, the bulk of the cases occurred in the intracranial location. And then you see the spectrum of the fusions that were uncovered in this series, where there's actually 2 that were EWSR1 with CREM. So I had taken, before all of this went down, my case to our neuropathology meeting, and then Angelica Oviedo at Nova Scotia and Caterina Giannini from the Mayo Clinic approached us and said, I think I may have one of these too. So we have 2 additional intracranial cases. So, oh my God, it's an epidemic. And it's interesting that there are some different features, although they all seem very similar overall, that are present within these different tumors. So the case from Nova Scotia had a much more lobulated appearance with a very well-formed but thin fibrous pseudocapsule. And then I think Dr. Giannini's case did have some of those blood-filled lake-like spaces that you see in classic AFH. The summary of genetics from the cases that I had now is that you had EWSR1 CREB1 in 2 of the cases, and in the actual 3rd case we found actually had EWSR1 CREM. So another thing that emerged, that 2 of the cases did have some fairly nonspecific gains in 5q and 11q. But when you subjected them to the whole exome sequencing panel, I didn't find any distinct mutational signature. So all the mutations we found were pretty much private mutations. And the panel that's run at the Brigham is not matched. So some of the variants were actually pretty consistent with probably germline SNPs. So we published our series in brain pathology, and it hopes to sort of try to push forward the question about what are, and bring more, I guess, awareness to these lesions that occur in and around the brain, and hopefully try to figure out a little bit more about, are they distinct from myxoid variant of AFH, or are they really just sort of a variant that occurs in an under-recognized location? And so some things to consider is that EWSR1 rearrangement with the Krebs family of genes encompasses a variety of entities, as we know, including AFH, including obviously primary pulmonary myxoid sarcoma, hyalinizing clear cell carcinoma of the salivary gland, GI clear cell sarcomas. So, there's a lot of different entities and a lot of different sites, some of which have histologic overlap, some don't. The MixWeb variant of AFH does have focal classic AFH features, and sometimes you don't really find them at all. But in all of the descriptions, or the one major description of the MixWeb variant, there were no intracranial cases described. Meanwhile, while we do have classic intracranial AFH cases described, none of them have ever been described in myxoid histology. And this one thing that's really interesting, that EWSR1 CREM fusions have not been identified in AFH, but as we saw in Dr. Antondescu's and Mark Rosenblum's series, it's not unique to the intracranial location, because the one case that was a perirectal mass harbored the EWSR1 CREM fusion. So I think there's more to be done here in terms of what are the significance of other genetic alterations. I'm glad to be able to harken back to some of the themes of this morning, which is that, I think as time goes on, we'll get more and more layers of information to try to figure out where these entities lie in respect to other described lesions. So it's an exciting time to be working on this. A little bit of follow-up, the patient that I have, and of all the patients that we have in the series that we have extended follow-up on, there's been no evidence of recurrence. I guess the one patient who had the perirectal mass did have some local recurrences, but so far it seems to be a very benign course. I do want to thank Angelica and Katerina and Sonda and Harry for working with me on our cases. Harry's actually an alum of this place, and he sends his regards. And thank you, Mark, for suggesting that I do this, and I look forward to working with you on this and other things.